All right. Thank you, Brittany, for the music. I feel like the last 10 minutes of listening to that, I just want to turn off my camera and start dancing. So welcome everyone to GME Grand Rounds. For those that don't know me, my name is Dr. Eric Hung. I'm the Director of Curricular Affairs for GME, and with our GME team, put together several of our centralized educational programs, GME Grand Rounds being one of them. Today marks this first Grand Rounds of the year, and I couldn't be more thrilled than to have Dr. Glenn Rosenbluth be our first GME Grand Rounds speaker for the year. We have a great lineup of speakers ranging from topics in professionalism, well-being, quality improvement in patient safety, diversity and inclusion, and it's just great to see so many folks connected. With that, a couple of just sort of housekeeping sort of ground rules as we get started. We will be monitoring the chat as we go, so feel free to put questions into the chat. I will ask questions for you, or we'll have a chance also at the end for folks to unmute themselves and to be able to ask questions to Glenn as well. So without further ado, let me introduce our speaker for today and our topic. So Dr. Glenn Rosenbluth, for those that don't know him, is a pediatrician who specializes in caring for children with medical complexities. He works on the pediatric hospitalist team, caring for hospitalized children with a range of conditions. Dr. Rosenbluth is the Director of Quality and Safety for our GME team, and he has a particular interest in understanding how to help residents and fellows engage in hospital-wide quality and safety initiatives. As part of his work in the GME team, he oversees our Reflect program, which I know that many of us participate in either as resident and fellow leads or as mentors. And this program really fosters, system level change across the system, and also brings some folks some extra cash when goals have been met. In addition to his GME leadership roles, Dr. Rosenbluth has been involved in several research projects studying the interface between medical education and patient safety. He has a leadership role in the IPASS study, the very foundational IPASS study, which we've all become familiar with, which has demonstrated significant reductions in medical errors and also preventable adverse events after the implementation of this handoff communication bundle. Today, we are going to be waking up to sleep deprivation, and I am really thrilled to, again, invite Dr. Rosenbluth to the GME Grand Round Zoom stage, and please give me a round of applause in welcoming Glenn today. Thank you so much.
I'm wondering if anyone knows the origin of this photo that's on the screen right now. I suspect not. This photo was a big social media photo a couple of years ago in Mexico. This is a physician who is taking a nap at a desk in a clinical area, and a patient got very upset when they were waiting for care and saw this physician with their head down on the desk and posted on social media the photo, sort of frustrated that their doctor was resting when they were waiting for care. And it actually led to a very large social media campaign in Mexico. This is about 5 years ago, called Yo También Me Dormí. And it was basically doctors and nurses and other healthcare providers from across the spectrum saying, I also fell asleep at work. And it was sort of a call to arms, that like acknowledgement that the healthcare providers are absolutely exhausted. And so it became really a sort of rallying cry in that medical community to try to improve things. So to that end, we're going to try to talk about how we can improve things. I don't have any disclosures or relationships. I'm going to start by just showing a quick video. This video is from the ABC News or ABC TV show called Hopkins. So this is interviews with real doctors from Johns Hopkins from several years ago. So I'm going to go ahead and share this.
I think a lot of people get used to sort of this chronic sleep deprived state.
I usually take little naps at traffic lights.
Yeah, it's a beautiful thing, and you wake up when the horn honks behind you.
Like,
The other trick is to take the ammonia capsules and break one and leave this on there, so when your head drops down, you sniff the ammonia and you wake up. Works pretty well.
The first night is always a little bit tricky because your body's adjusting to being on nights.
Usually on your 5th or 6th night, you're biting everybody's head off. Everybody's biting your head off. We're all stir crazy.
I'm looking forward to a big finish next year and actually catching up on about 15 years of sleep deprivation.
If I can sleep a solid 6 hours, I feel great. If I sleep over 8 or 9 hours, then I feel kind of sick.
Most of my surgical resident colleagues will tell you that as soon as they hit the pillow, they're out cold, and it's going to be very difficult to wake them up unless they hear the alarm or the pager.
So I don't know, does that sound familiar to anyone? I certainly know that feeling of being exhausted. And in fact, I remember the tiredest I ever felt was on rounds during my intern year after a long night of call. And a nurse pulled me over to see a kid who was in respiratory distress. And I took one look at the kid and I looked back at the nurse and I just said, I'm too tired. I'm not thinking straight. You need to call someone else. And that was for me an important acknowledgement of the importance of sleep and the challenges of not getting enough sleep. So what we're going to do today, going to talk through some basic sleep physiology. And if there's any sleep fellows who are on, please feel free to interrupt me if I get anything wrong. We're going to review the impact of sleep deprivation on physician and performance. And that's going to include some contextual factors, including we're going to touch on the role of racism in sleep deprivation. We're going to talk about impact on cognitive and procedural processes. And then we're going to talk about some interventions which can reduce or mitigate the impact of sleep deprivation. So you leave with something, not just hearing how bad the problem is, but what you can do about it to help protect yourself. So just a note on the history of duty hours that I like to put up, that prior to 1989, there were no duty hours anywhere. And many of you know that the term resident is a holdover from when doctors actually lived at the hospital, or doctors in training actually lived at the hospital. New York has had duty hours for over 20 years now, or over 30 years, I guess. The Europeans are far ahead of us. And I put this one up just to remind you or inform you if you didn't know. The European Work Time Directive actually technically limits doctors, including doctors in training, to 48 hours a week. Not everyone is compliant with that, but I put it up there as we're going through things just to remind us that there is another way to do things. It's not only the US way where we have to work people to death. And then the timeline, there have been lots of iterations of AC GME duty hours, starting with in 2003, at the end of my intern year, was when the first set of duty hours came in place. Prior to that, we could easily work 34, 36 hours straight. Mine was the last intern year when you could have a full day post-call. Then in 2011, there were much stricter requirements that went in. And then in response to some data that I'll share, in 2017, the requirements were loosened again for a variety of reasons. So I'm going to start with just a little bit of sleep physiology to remind us that there are two different processes that drive our sleep. One is our circadian rhythms, which impact our timing of sleep. And circadian rhythms are independent of the amount of sleep. They're just our drive to be awake or our drive to be asleep. And then, and they also impact hormone secretion, temperature fluctuation. Those of you who have been walking around the hospital at 3 in the morning and you're like, I just need a blanket or I need my jacket or something, I'm freezing, even though the temperature in the hospital hasn't changed. And then there's your sleep homeostat, which is your sleep drive or your sleep counter. So to just give a little sense of how these play out over the day, the red is your sleep drive. And what this is showing in time is, let's say you wake up at 7 in the morning, over the course of the day, your sleep drive increases as you get more tired. So this is just increasing sleep drive until you go to sleep. Let's say you go to sleep at 11 o'clock at night and you recover and your sleep drive goes back down to baseline. And then this is showing the same process that happens if you were to stay up for a prolonged shift. So you're working past 11 p.m. And then you get this additional sleep pressure beyond what you would usually have. So that's increased drive to sleep. And that's what we know is feeling tired. And then our circadian rhythms are driving this drive to be awake from 7 a.m., drive to be awake throughout the day. And then towards the afternoon, you start getting a little bit of a drive to be asleep throughout the night. And then it sort of resets throughout the day. And this is just relevant, and we'll come back to this because it impacts when napping is most efficient. So if you try to take a nap here, as your circadian rhythms are driving you to be more awake throughout the day, you're not going to have a very efficient nap. On the other hand, if you try to take a nap at a time when your circadian rhythms are sort of shifting over and making you a little more tired, that's going to be a better nap. That is also the reason why in the middle of the night, when you're at the sort of bottom of your sleepiness, you've probably had that feeling of, if I could just make it to 4 a.m., if I could just make it to 5 a.m., I'll be able to survive this call night. And that's when you're sort of at the dregs of, you have this increased pressure to sleep. Your pressure to sleep is at its maximum. And then if you can just turn this corner around 6 in the morning, 5 or 6 in the morning, then your body's like, okay, I can stay awake another 6 hours now that I've made it through. So those are two of the processes that really impact residents and the way we sleep. And then the other thing to know that's relevant to being on call is sleep inertia. What sleep inertia means is that when you're asleep, your body wants to stay asleep, and it's hard to wake up. And so many of us have had that feeling of being asleep and your pager goes off, and maybe you're not completely awake and you're sort of shaking off the cobwebs. And many of us have had stories of getting woken up in the middle of the night and talking to someone and then kind of remembering, wait, what did I just say? What did I just do? And that's a particular concerning thing. And when we talk about taking home call, when we talk about sleeping during a clinical shift, that's a risk we have to be aware of. And we'll talk about that in terms of the pluses and minuses of blue light filters and trying to conserve sleep while actually being awake enough to provide the right care that your patients need when you get called in the middle of the night. It's a very, very delicate balance. So that's all I'm going to say about sleep physiology. Again, if anyone wants to jump in on that, please feel free. So just a little bit about the scope of the problem of sleep. This quote always hits me. I always had a prior theory that when you look up all the old 60s research, how do you brainwash someone? You sleep deprive them. That's number 1, 2, and 3. Sleep deprive them. You feed them bad food and you repeat things over and over again. It's kind of like that covers residency. Hopefully the food's gotten better and hopefully you're less sleep deprived, but this always resonates with me. So I'm just curious, just to get a sense of the audience, and I think Brittany set up a poll, just to give us a sense of what's out there. What is closest to your average night's sleep for those who are able to participate in the poll? I think I am not able to see. Brittany, are you able to share the results?
Yes, I can share when we're ready to end the poll.
Say again?
I said I can share the results once we end the poll.
Okay.
Glenn, I
can
think
share them anytime, or just shout them out if it's easier to. Oh, great. Okay, so most people getting, it looks like, closest to about 6 hours of sleep a night. Thankfully, nobody's averaging 4 hours a night or less than 4, so that's great. So this is a starting point because we're going to talk about what sleep deprivation does to our performance. So sleep deprivation, as we think about it, is a lack of adequate sleep to achieve restfulness. So that's going to be different for different people. And sleep deprivation comes in acute. So that's like the single all-nighter that you pull, that's a one-off. Chronic sleep deprivation, which is what many of us have from sleeping less than 8 hours a night or less than we would ideally like. And then there's acute on chronic, which I think of as residency and fellowship, when you're not getting enough sleep at baseline, and then you try to pull a 24 or 28-hour shift on top of being sleep deprived at baseline. And that's when we get into the acute on chronic. And I'm going to talk a little bit about the different kinds of impairments that can happen as a result of this. So before I go on, I always just ask the question, is anyone here an X-Men? Or is anyone here any kind of superhero? Because if not, then we have to accept the fact that this is all human data, and this actually does apply to us. I know as doctors, we think we're superhuman sometimes, but these are data that are actually from real humans, college students, graduate students, and physicians out in practice. So they do apply to us. So I'm going to start just by talking a little bit about how much sleep deprivation is significant. And this is a series of classic studies that was done about 20 years ago, looking at the impact on a variety of psychomotor tests between people who get no sleep for 3 consecutive days, who are just kept up in a lack of sleep lab, people who get 4 hours a night, 6 hours a night, and 8 hours a night on a variety of testing. And one of the things that I like to point out is that, I mentioned that notion of chronic sleep deprivation. So if I just draw your attention to this top panel, what you can find is, so in this graph here, this is 1 night of sleep deprivation. And what this is showing is, I think I actually have it in a better, there we go. This is called a performance vigilance test. And what it does is it puts on the screen a little dot that lights up, and then it times how long it takes you to notice that the light has come on. And in this case, it's 318 milliseconds that the person tapped their finger. What I want to draw your attention to is if you start with people who are at normal baseline restedness, this is 1 night of sleeplessness, and they have about 8 lapses. And this middle line is someone who gets 6 hours a night. That was our most popular answer of how much sleep you all get. And so this is basically making the point that if you take 2 people at baseline and give one person a night of sleeplessness, that actually equates out to what someone who's only getting 6 hours of sleep a night on a regular basis, what their performance level is. So there is some detriment in those people who are only getting 6 hours a night. If you get them back to their baseline, they actually have very few lapses. But if they're chronically getting 6 hours of sleep a night, they do have real impact on their performance. And this is a classic study from the 90s that compares the impact of being tired versus the impact of being drunk. And what this graph is looking at is over hours of wakefulness. This is the average performance on one of those psychomotor tests. So basically they look at individuals, figure out their baseline is, and then say, at what point on the spectrum is your performance above average? And at what point on the spectrum is your performance below average? And that's the 1.0 line. And this is basically showing that at about 16 hours of wakefulness, that's when your body crosses over from your above average performance to your below average performance. And that's actually why about 10 years ago, the ACGME had that 16-hour limit for interns. That's where the 16-hour originally came from, this notion that 16 hours is when you get half your baseline. Now, if you also compare this to same kind of measure of performance against blood alcohol concentration, what we find is when you get out to about 24 hours of wakefulness, that's when you get down to a level about 0.94, about 94% of relative mean performance. And that's the level that you get at when your blood alcohol concentration is 0.08. So that's where the data comes from, that being awake for 24 hours puts you at about the legal limit of being drunk. So I put that out there just to let you know that these things actually are derived from evidence. It's not just speculation. I want to now just acknowledge that sleep and work exist in a broader context, especially for residents and fellows who don't have as much control over their lives. So we're sleeping in the context of our relationships and our families. Some of you might have new babies at home. That is absolutely going to impact the amount of sleep you get. Some of you have children, school-age children. That's going to impact. Some of you may be caring for adult family members or who have other adults in your home, and that may impact how much sleep you get. I also want to acknowledge socioeconomic factors. The San Francisco housing market is such that people may not be able to live in the quietest, darkest area. We know that sleep is better in more rural areas where there's less ambient light coming in through the windows and less street noise. That's not really possible in San Francisco. And also I put up medical debt because some people may have their sleep impacted by moonlighting that they feel they need to do to actually acknowledge that. And then I'm going to talk for a minute about the impact of racism. I will also acknowledge that structural racism certainly plays into the housing market and medical school debt, but I'm going to talk about some specific, more individual things. So if we look at racism and sleep deprivation, there's pretty good data that shorter sleep deprivation is more common in Black identified individuals in many fields. And I'm going to talk about some of the reasons for this. But when you look in healthcare, there is definitely an increased prevalence rate. and it's across many fields. And the hypotheses around this have to do with a complex interplay of workplace discrimination and increased work ethic. So this was an interesting bit of reading that I did on this topic. There's this sort of theory of what's called John Henryism. John Henry was that folk hero who was worked on railroads and worked so powerfully and so hard that he physically hurt himself and basically drove rails to death, drove himself to death. The thinking with John Henryism in this context is that if there's a strong behavioral disposition to confront adversity, in this case, structural racism being an adversity, coupled with high effort coping, that impacts people's ability to get sleep and to take care of themselves. So if someone feels that they're facing adversity and has such a good work ethic that they're trying to overcome that adversity by working harder, that's going to affect the ability to get sleep. The same comes up in the notion of stereotype threat, where individuals who feel that they may be discriminated against may adopt certain behaviors, such as showing up early, being the last person to leave at the end of the day, that may project them as working hard to counteract stereotypes that may exist. There's also data on racism and sleep quality. So that was quantity. But we know there's some good data that individuals who experience more discrimination have less stage 4 sleep. That's from a Black identified population. Exposure to both overt and subtle discrimination are related to lower subjective reported sleep quality. This is in Latinx and AAPI identified study populations. And then there's this notion of racism-related vigilance, which is anticipation of racism, which leads to greater sleep difficulty in Black and Hispanic identifying adults. So people who know that when they're going to experience racism are going to have less sleep. I don't have the data on this. I suspect the same data would come up with gender-based discrimination or sexual minorities or any group that is knowing that when they show up to work, they may face a certain amount of discrimination. So all of these are going to impact the amount of sleep and the quality of sleep that people are able to get. So acknowledging that it's not just the vacuum that happens in the hospital, and the experience is not the same for everyone. So how do we put this in context? It actually might be possible that duty hour restrictions serve as guardrails against some racism-induced sleep deprivation, but it's also possible that duty hour restrictions increase stress in some individuals and therefore actually worsen sleep. What I can say pretty confidently is there are likely many other intended and unintended consequences. And so that's why we want to be able to have these conversations and talk openly. It's one of the reasons why the GME office really wants to hear from residents and fellows about the experience. I also want to talk about the effects on language. We know that when we're sleep deprived, we make more mistakes with complex language tasks, like giving a lecture or like presenting on rounds. Right? There may be some patients for whom it feels like presenting on rounds is autopilot, but if you're talking with a patient and having a complex conversation, you're more prone to errors. We also know that there's decreased vigilance, which may have impact when we're speaking in a language that's not our native language. I apologize. I'm trying not to use the term foreign languages, but rather refer to non-native languages for whoever the speaker is. But just highlighting that we want to have increased use of interpreters in the setting of decreased vigilance because we're a little bit more sleepy. It becomes all the more important to make sure we're using interpreters to be careful with our language. And we know all of this does impact doctors. This is just one example of some relatively recent data I published this year, going back to those psychomotor testing, comparing the top graph is doctors on shifts longer than 16 hours, and the bottom line is doctors with shifts less than 16 hours, and basically showing that the doctors with shifts longer than 16 hours have more attentional failures or lapses and have, in this graph, slower reaction times on those tests. So they may miss a step altogether, or they may just have a slower reaction time. But these are data from this year that recently came out of the Boston programs. We also don't know when we're sleepy. This is one of my favorite studies. This was out of Stanford. So what they did was the researchers took anesthesia residents who were tested post-call, and they give them a sleep latency test. and an EEG, which basically means they put them in a dark room and say, do whatever you want in this dark room. Like you can lie down, you can close your eyes. We're going to monitor you with an EEG. And then they measured two things. Did the people sleep? And did they think they fell asleep? And the outcome was that residents were wrong 76% of the time when they thought they had stayed awake. So people just sitting there said, no, I didn't fall asleep, but the EEG showed they did. So basically making the point that we don't actually really know very well when we're sleepy. So I'm going to just go through relatively quickly some of the other data on medical errors and duty hours, because I think this comes up a lot. Why do we have the duty hours and why do they matter? So one of the landmark studies that led to the first set of duty hours was out of Boston, looking at medicine interns who were working Q3 call with a max shift length of 34 hours, because that was still allowed, and still only averaging about 80 hours per week in the hospital. And they compared them to medicine interns working a shift schedule with the max length of 16 hours and averaging only 60 to 63 hours per week in the hospital. So shorter shifts and fewer hours in the hospital. And no changes to the supervisory roles, some changes to the sign-out process. What this study found was a significant decrease in rates of medical errors. The intervention schedule had a lot fewer medical errors. It probably didn't, or it didn't have a statistically significant decrease in preventable adverse events, those preventable harms, those harmful errors, though there was a trend in that direction. And then what I think is actually really interesting is there was a pretty significant, though small numbers, decrease in diagnostic errors. So those cognitive things that we have to think through, there was a really impressive decrease in diagnostic errors. What about surgical tasks? People sometimes say, oh, cognitive is different than procedural. Comparing control surgeons to surgeons who are in the middle of a call shift to surgeons who are kept up all night. Number of errors and time taken to complete a laparoscopic task. Basically, again, making the point that as you decrease the amount of sleep that you have, you're making more errors and it takes more time to complete the task. Same thing has been shown in attendings, or a similar version of it, looking at attendings who operated during the day after having operated at least part of the prior night, to actually physicians serving as their own controls, a surgeon performing the same procedure without having operated the prior night. The subgroup who had less than 6 hours sleep opportunity had more complications. So maybe 6 hours is a reasonable cutoff, but once you go below that, there's a higher rate of complications. And then to make the point that we also hurt ourselves. So in some of these same studies in the mid-2000s, interns working 24-hour shifts have higher odds of crashing their cars when driving home after work, an odds ratio of 2.3, near-miss car accidents with an odd ratio of 0.9, and needle sticks in the hospital with an odds ratio of 1.6, and more common at night, it goes up to 2.0. So there's a lot of things that we need to be doing to protect ourselves. It's not just our patients, though obviously our patients are front and center in this. So I don't know, are you convinced we have a problem? What if it were your loved one? So I'm interested in responses to this question. A resident is assigned to do a lumbar puncture on your child or your family member. She seems fine, but it's 5:30 in the morning, and you know that she's towards the end of a 24-hour shift. You don't see a supervisor around. What would you do? Only one person said that they would be comfortable in that situation, and yet it's something that we actually see happen relatively often, right? We've all done procedures towards the end of a shift. So why would we do things to our patients that we wouldn't be comfortable with for ourselves and our loved ones? So there is another side to this that I want to acknowledge. We can't force people to sleep, and data show that just because you give people time off, especially residents, they will not necessarily spend more time sleeping. Also want to acknowledge that the sleep safety correlation is not perfect, and that individual differences do exist. There are such things, and I'll come back to this, as super sleepers. Most of you, I suspect, are not super sleepers, but there is a small group of people in the world who really can function on 4 hours sleep. And then duty hour restrictions alone don't necessarily predict fewer hours. So some of you may know about the first trial, which was the flexibility in residency and surgical trainees. and basically compared, this was it was published in 2016, surgery residents working under current duty hour guidelines compared to surgery residents in programs that had flexible duty hour guidelines, so they could work longer shifts, but were still limited to 80 hours a week. And overall, there were actually no difference in the outcome measures for patients. But what I want to say is this was large Medicare data sets. The data that I showed you from Chris Landrigan from the interns study from 2004 was actually doing hard chart review. And I'll talk about some of those differences in a minute, what you can find with chart review versus large data sets. But one thing I will show you, there was a tremendous amount of data from the first trial. Comparing the group that had, at that time, standard was the shorter shifts versus longer shifts. These are all clinical things like the perception of negative effect on patient safety, continuity of care, clinical skills, operative skills. The residents tended to feel that there was less negative effect, more positive effect on clinical measures when they could work longer shifts. So that was a perception of a safer and more effective hospital environment. On the other hand, when you ask them about their impact on their own case preparation, participation in research, professionalism, morale, time with families, the people who worked longer shifts scored worse, or rated these metrics, most of the metrics worse. So a more negative impact on their personal lives and their academic preparation when they're working those longer shifts. The iCompare trial was basically the same thing in medicine, also using large data sets. The first trial used the NSQIP data set. This one was Medicare data sets. And again, no difference in clinical outcome measures using large data sets, looking at high level metrics like 30-day mortality and other safety metrics as secondary outcomes. But it's worth noting that the interns in that flexible group with longer hours were less satisfied with their education. However, the program directors were actually more satisfied with the residents' education. So hard to know where to settle that out. The other thing to note about the iCompare trial is when they were looking at mortality and readmissions, they set a 1% non-inferiority margin. So the thinking was, is 1% worse mortality? Is that the right number? Maybe just for time, I'm not going to go into that, but just to think about that, if you had 244,000 admissions, as this study did, then a 1% difference is 2,440 patients. But obviously scale down to the mortality and readmissions. It's just to say these things are all really hard when you're doing large data sets. So personally, I put a little more stock in the studies that actually look at the data or look at the charts and try to capture some of those things that you can't capture. Like, for example, a large Medicare data set isn't going to show a patient who maybe bumped their creatinine and had one extra day in the hospital because of a drug dosing error, or maybe got one extra phlebotomy because the lab wasn't ordered right the first time and had to be ordered a second time. Things like that that maybe aren't such harmful errors, but if it's you, it's impactful. And then one final study that just came out last year, looking at a cross-sectional survey of 7,700 attendings and 3,600 residents, basically found greater sleep impairment associated with increased odds of self-reported clinically significant errors. So people, the more sleep deprived you are, the more likely you are to report that you were involved in a medical error. So what does all this mean? We don't perform as well when we don't sleep. Our patients probably experience more errors when we don't sleep. And the impact varies by methodology. Studies with direct chart review show greater impact and large data sets show less impact. So a lot of different ways to look at the data, talk about the data. But again, the methodology really matters. The other thing I want to point out that I think these data show is that duty hour restrictions alone are not the answer unless we get tougher. So the only real impact that started to be seen in the Boston study was when you both limited shift hours to 16 max and took people down to about 60 hours per week in the hospital, which I showed the European data to just make the point. Nobody's worried about whether European doctors are well trained, even though they only work 48 hours a week. I acknowledge that the European training system is different and longer. I just put it out there to say there's another way to do things. We've decided that we have our way of doing things, but there are other ways to think about training that may be more conducive to better sleep and improve patient safety. So what's keeping us from getting tougher? a lot of things, money being one of the big things. When the Institute of Medicine put out their recommendations in the mid-2000s about decreasing duty hours significantly, that they actually said they shouldn't be implemented unless enough money is committed to make it happen. And then I just asked this question, should we err on the side of safety? We've decided that truck drivers can only work 14 consecutive hours, and only 11 of those hours can actually include driving. Pilots are only allowed to fly for 8 hours in a 24-hour period, and they must have at least an 8-hour period of rest in 24 hours. So we've decided that other fields can have restrictions. This is a little bit morbid, but my belief of why we've decided why truck drivers and pilots have allowed themselves to be restricted is, if you think about it, again, I know this is morbid, if a pilot makes a mistake, they go down with the plane. I asked the question, in all seriousness, if we had to experience whatever our patients experience, if we had a bump in creatinine every time we made a mistake, if we had an extra phlebotomy every time we forgot to order labs the first time on a patient, would we think about rest differently if we were the ones experiencing the impact? I don't know. Is it different if you're a super sleeper? There was this great story in UCSF magazine about super sleepers. Probably it is. There are people who need less sleep, but I don't know how to test or verify that. Just as I don't know how to ask my pilot who says, you know, I've been up for 18 hours, but I'm a super sleeper, so I feel good about flying the plane. I said, I don't care. I kind of want you to go to sleep. Is it different when you're an attending because you have more control of your schedule, more time out of the hospital? I don't know, probably. But I think there's also some self-selection that goes on. So I'm going to wrap up just by talking a little bit about interventions, which can reduce or mitigate the impact of sleep deprivation. So some things we can do to improve our sleep, optimizing our sleep environment, that dark, cool, and quiet environment. So dark and quiet, that gets back to what I was talking about. San Francisco, it may be hard to find that sometimes. Also, it's considered a best practice to only use your bedroom for sleep and for other adult intimate activities, but not to use your bedroom as a place to put your laptop on your lap and go into Apex and do charting in bed. If you have a sleep disorder, we have sleep medicine at UCSF and we can get you a referral to get treated. Alcohol tends to cause lighter, less restorative sleep, so we recommend against or minimizing alcohol use. Exercise, having a regular exercise regimen can be helpful to developing a sleep regimen. And sleep before and after call. It's very helpful to actually get yourself sleep in those hours, especially going back to when the best time to nap is. If you just work a 24-hour shift, it may be hard to take a good nap at 9 in the morning when your body's trying to be awake. If you can sleep in the afternoon, that's going to be a much more restorative nap. Use technology, turn on that do not disturb on your iPhone. Minimize smartphone use at night if possible, but I put this out there that, you know, our phones have this night mode and these blue light filters that help prevent us from being so startled by the light of the phone. On the other hand, if you're getting called about a clinical issue, the light may actually help wake you up when you're talking to people. So if you're actually answering clinical issues at night, it may actually be good to not be on night mode because you actually want to be awoken to be able to have a coherent conversation. Cues to inadequate sleep, falling asleep in conferences or on rounds. I can't tell if anyone's asleep on this one right now, but feeling restless and irritable with staff, colleagues, those are all signs of inadequate sleep. Sleeping very late on weekends. Obviously, everyone sleeps in a little bit on weekends, but if you find yourself sleeping until noon on the weekends, or everyone catches up on sleep during vacation, but again, substantially. Having to check your work repeatedly, difficulty focusing on care, and then feeling like you don't care. There's a certain amount of apathy that can come in even in physicians when we're sleep deprived. And I pulled this quote from the book. Some of you know the book House of God by Samuel Shen, which is it's a satire, it's a novel about healthcare. But he writes, upstairs, I had just finished working Jimmy over, putting in lines and tubes and starting to treat his untreatable diseases when Mrs. Reisenshine arrested, and I was surprised to hear myself cursing under my breath as I resuscitated her. I wish she would just die so I could just go to sleep. And I was shocked when I realized that I just wished a human being dead so I could go to sleep. Animal. Now, hopefully nobody's ever had that quite extreme reaction, but there are good data that we become more apathetic and less compassionate when we're sleep deprived. The following things do not keep you awake: turning up the radio, opening the car window, chewing gum, blowing air or water on your face, promising yourself a reward for staying awake. None of that actually helps keep you awake. So to deal with fatigue in real time, some of the things we can do, strategic napping does help, taking naps at the right times. Again, when your body's the sleepiest, that 20-minute nap can make a huge difference. Judicious use of caffeine. Caffeine works. And recognizing fatigue in yourself and others. So that's why we talk about, if you see some of these signs in others, please speak up. So the best naps are going to be between 2 and 5 a.m. or 2 and 5 p.m. Because again, going back to those circadian rhythms, it's not a replacement for a night's sleep, but it will help. Caffeine and Provigil, they don't solve the problem. It's like giving Tylenol for fever, but it can help you get through a shift. And I just put out there to give you a sense of the different ranges of caffeine that are in things. So Starbucks Grande coffee is 330 milligrams. On the other hand, McDonald's coffee is only 130. Starbucks really is a lot more caffeinated. A Starbucks Grande decaf is 25 milligrams compared to a Diet Coke that's 63. So a Starbucks decaf has almost as much caffeine as half a can of Coke. And then my stepbrother just turned me on to these Verb energy bars. I don't use them, but they taste good. But yeah, another way to get caffeine. Driving while tired, I just want to remind us again that car accidents are more likely after working shifts more than 24 hours. So this is residents just like us. Rate of car accidents per 100 or per 1,000 commutes. In this data set, if you have 1,000 commutes, there's a likelihood that you're going to have an accident. So you're too tired to drive. If you have trouble focusing on the road, if you have difficulty keeping your eyes open, nodding, yawning, obviously, you know, these would all be very concerning signs that you'd be too tired to drive. And so I just remind us that we do have taxi vouchers at all of our UCSF sites at Mission Bay, Parnassus, ZSFG, and the VA. And if you must drive when you're tired or post-call, please consider like taking a 20-minute nap before you leave, drink a cup of coffee before you go home, a couple of sips of coffee, even just to get some caffeine flowing. And if you notice the warning signs of sleepiness, please, please, please pull off the road at a safe place and take a short nap. So I'm going to stop there and leave. I think there's a couple of minutes left for questions. And if anyone's still awake, I'm happy to entertain any questions.
Wonderful. Such an amazing talk. Thank you, Glenn, for going through it all with us. Just as a reminder to folks, feel free to put questions into the chat, or you can also unmute yourself if you'd like to ask a question directly. There was one question, Glenn, that came in the chat that I believe you answered around caffeine and also the perception of caffeine and its impact on sleep deprivation. But Jesse says that you've already answered the question, so I think that one might have been addressed already. Other questions?
Amber's asking about strategic use of caffeine. Do you also mean in terms of how often we choose to drink it?
Yeah, I think there's a reality, like the internists on the call could probably answer better than me, but there are some benefits to daily caffeine use. But I think when I say being strategic, I mean being cautious that we're not using it at the end of the day in a way that's going to keep us up at night and keep us from falling asleep. And then on the other end, if we do have to drive, or if we are going to be responsible for patient care and we're feeling sleepy, caffeine can be helpful to have us be awake enough that we're providing the right attention to the situation at hand.
Glenn, a question has come in from Nadia around system level kind of interventions, system level solutions, and which ones work best. Can you kind of expand on system level solutions that go beyond work hours?
Yeah, well, I do want to say within the realm of work hours, one of the reasons why we think work hours haven't actually worked to solve the problem is that often when we restrict work hours, we rearrange the deck chairs, so to speak. There's still that same amount of work to be done and the same number of people to do the work. And so we still end up tired. what the IOM said is we actually need more people working, more people to do that work. And the Boston groups, when they've done their intervention schedules, they actually have sleep experts saying, okay, well, you should go from a day shift to a swing shift to an overnight to a day off. Because it actually is easier to keep yourself awake in that sequential way rather than going from a swing shift back to an early morning wake up. So they're very cautious, and that's just not an option that's available to most chief residents who make the schedules. So we really do have to think differently about the way we're creating the schedules. And then I think we do, I personally think we would benefit from taking a page from what the nurses do of actually taking breaks and handing off and make it okay to go down to the call room and put your head down, but normalize, get away from this notion of the doctor as the hero who can stay up all night and respond on a moment's notice when the pager goes off, and transition back to this awareness that we are human and we do need sleep, and we're all going to perform better for ourselves and our patients when we are able to get more sleep. I recognize this is a really hard talk to give residents and fellows who don't have control over their schedule, but it is sort of meant to sort of highlight that there are ways that we can change the system, and there's a lot of us that have been working to try to push forth some of those changes.
Maybe if I can just make a comment on the taxi voucher piece, we actually just refilled all the taxi vouchers at the sites. If for some reason you go to one of the sites and they are out, because security is supposed to let us know when they're running low, but sometimes they don't always do that. One, please let us know. Two is if they are out of a taxi voucher, you can Lyft or Uber or whatever home, and then please send us the receipt and we can reimburse you.
Some of you know that we did try a pilot with rideshare services a couple of years ago, and there were just some technical logistical issues that made it impractical to impossible. So taxi vouchers are still the solution for now.
Any other questions before we wrap up for today? All right, well, on behalf of everyone participating today, Glenn, thank you so much for an amazing and wonderful talk. It's great to see everyone over Zoom, and we will see you for an upcoming Ground Round series. Thank you so much for joining.
Thanks, Glenn. That was really terrific.
Thank you. Appreciate everyone's engagement. Bye-bye.